Hello, I'm David Kerr, Professor of Cancer Medicine at the University of Oxford. I've talked many times before about, as medical oncologists, that which we can control best in terms of the treatment that we give is dose and schedule. Of course, we're interested in germline genetics, we're interested in the tumour biology. These are things that we can't control. These are things which are inherited. These are things that we can adapt our treatment to, but not control. Dose, though, is something that we hold within our own hands. This is something, an interesting discussion that we had recently in our own clinic. I think the world's drug supply chains have been disrupted hugely by world events, pandemics, wars, I'm sad to say. And we're running short of folinic acid, and we use folinic acid in combination with 5-fluorouracil because there is compelling molecular evidence to show that folinic acid enhances the cytotoxicity of 5-fluorouracil. The molecular mechanism is well worked out. Ternary stabilization of the complex of F-dump with this target enzyme thymidylate synthase. And a dear friend of mine, Emery de Grammont, introduced the de Grammont regime, in which relatively high dose folinic acid has been used for decades. But there's compelling evidence, some of our own, some from the German group, some elsewhere, suggesting that we don't need high dose folinic acid. There are randomized trials comparing high dose with low dose, given in bolus, given with infusion 5-FU, and it makes no difference. But the difference in dose is tenfold, and therefore it was easy for me as a clinical pharmacologist to say to my colleagues in Oxford, in this time of straitened circumstance of drug lack, let's just give the lower dose of drug, and without doing any disservice to our patients whatsoever. And there's a nice article in Lancet Oncology with Ian Tannock, an old friend of mine, old in the sense that we've known each other for a long time rather than to do with chronology, with Ian Tannock and his colleagues, in which I think they've written a very compelling article about how we can make immune modulatory drugs more widely available in low and middle income countries. They've done I think a fantastic retrospective review of the phase 1 trials, the dose scheduling, the pharmacokinetics of immune checkpoint inhibitors. And what they're saying is that the dose that we use in the West is far too high. I think they provide good evidence to suggest that we could give lower doses less frequently. And in fact, in their calculations, if we use their dose modifications, all of them rational, all of them based on strong underpinning clinical pharmacology, we could use the dose regime that would allow us to treat one patient in the West. We could treat 20 patients in lower income countries. Have a look at the article. Thoughtful, thought-provoking, and shows how, again, dose is something that we need to understand better. I moan a lot to our junior staff about how, although they know everything about next generation sequencing, they know nothing whatsoever about clinical pharmacology. The sort of pillars upon which much of therapeutic medicine is based seems not to be taught in modern medical schools or to the next generation of clever young oncologists. So a thought-provoking article from Ian and colleagues, practical outcome measures that could be made. The immune checkpoint inhibitors are on the WHO list of necessary anti-cancer drugs, but they're way beyond the reach of most individuals and most low and middle income countries. And here's a practical evidence-based solution as to how we could deliver those drugs more equitably and fairly excuse me, around the world. Have a look. Very interested in comments. For the time being, Medscapers ahoy. Thank you.